TSPN. And now back to today's Seniors Living Well with your host, Laurie Webb.
Hi everyone, welcome back to today's Seniors Living Well. We're talking about the whole spectrum of life today, and I just had the pleasure again of talking to Bill, who's had a very full and long and to be continued life. Dan mentioned ICU in his presentation about having the conversation about how you want the end of life. And it was a perfect lead-in because joining me as my final guest this morning is Johanna Vermelfoot. I wasn't even going to try that one.
Okay.
And Johanna, you're a nurse.
I am.
And how long have you been a nurse?
I've been a nurse for over 30 years.
Me too.
Yes.
Yeah, it's a great profession,
It's
isn't it?
an awesome profession, yes.
Have you always been an ICU nurse?
I've been an ICU nurse or an emergency room nurse.
Aha. I have great admiration for that. I'm a home health nurse, and it's a much calmer kind of environment. So you work at Sutter Amador ICU?
I do.
And how long have you been there?
I've been there since 2012.
So relatively new.
Relatively new.
Yeah,
And I've been given this opportunity to be the lead on this new ICU Liberation transition for our intensive care unit at Sutter Amador.
ICU Liberation.
Correct.
Talk to us about that.
It's a very complex process of changing the way we care for our patients that are most critically ill. So Sutter Amador Hospital, along with 6 other Sacramento Sierra Sutter hospitals, is implementing ICU Liberation. This is through a grant from the Irene Moore Foundation.
Wonderful foundation.
Absolutely. They are very dedicated to improving health care.
Mm-hmm.
And for this past year, we've been concentrating on implementing new processes in the ICU.
Mm-hmm.
So we are working on identifying patients who are experiencing ICU delirium. It's been noted through evidence-based studies, specifically Vanderbilt Medical Center, that 60 to 80% of patients in ICU experience some level of delirium that has in the past gone unrecognized or untreated.
Really?
So we're trying to be very proactive in identifying that. Patients that are on life support, we're trying to keep their sedation lighter. Used to be, in the olden days, we thought we should keep them totally sedated so they had no recollection of being on life support. Now we're seeing that that was the wrong thing to do.
Really?
So we are keeping them lightly sedated or absolutely no sedation if they can tolerate it without being put under at all. And we're trying to use a pain-first approach.
Pain first.
So we want to identify if they're having pain and dealing with that first and hoping that if they can keep their pain under control, they will use less sedation.
So we're not talking about people who are necessarily dying. We're talking about people who are critically ill and requiring the life support, like the ventilator and all the tubes and
Correct.
all those
all the invasive
monitors,
things
all
that
those
we
things.
do in the intensive care unit. Yes.
So you have those patients that you're trying to keep their sedation a little lighter. Does that actually prevent the delirium? Or
It is one of the factors that increases ICU delirium. There are many, many factors that can create delirium for patients. Just being critically ill is one of the factors. But being sleep deprived or being too heavily sedated, not having a sense of day and night, not being oriented to their surroundings. So we're asking families to be very involved and keep talking to the patients even if they're under some level of sedation, to let them know that they are in the intensive care unit and their family is here with them. And it's been shown that a lot of patients will experience post-traumatic stress disorder if they're in a delirious state for too long, and that can last up to years.
Wow.
So
it's
really something that we've become passionate about identifying and treating.
Because you stop and think about, and we have a lovely ICU. I have not ever been a patient in it, but I've spent time in there, and was very encouraged by the staff to be there with family members that were and friends who were, being cared for. And that was different from when my dad had a heart attack many years ago, and I wasn't even allowed in because I was just the daughter. I wasn't a mom or the wife.
Yes, we've come a long ways. We used to be very limiting to who would be allowed to enter the ICU, and we would limit visitation to just a few minutes. And now we are encouraging family to be present as much as possible.
And our ICU is really beautifully laid out.
It is.
And each room is, you can kind of close it off. And,
yes, they're all separate rooms, and they all have doors, glass doors, so we can actually observe the patients, but the family and patients can have privacy.
So when a person comes into ICU and they're not necessarily on life support, but they're critically ill, are there some different approaches that you're using with them to deal with this delirium thing?
Actually, we're using the same approach whether they are or are not on life support.
Okay.
So I've been working with the staff to implement some new tools for assessing our patients. So we are doing what we call a RASS assessment, which is a Richmond arousal assessment tool, and then a CAM assessment, which is an evidence-based tool to use to identify patients that are having some delirium. And we're doing that on every patient that comes into the ICU at least once every 12 hours.
So now these tools are not medical devices, they're actually
No, actually
interactions that you have
Right.
with the patient.
Correct.
Can you kind of maybe describe one of those, what
Sure.
you
So
do?
patients will see the nurse coming into their room. They'll try to stimulate the patient's arousal just by using their voice, and then they will ask them some questions. So we want to see if they're having any inattention or disorganized thoughts. So the nurse will ask them to squeeze their hand, and then ask them to squeeze only when they say the letter A. So they'll say a series of 10 letters, and they need to be attentive enough to be able to squeeze only on the letter A and not on other letters. And if they fail that part, there's actually 4 parts to the test, the assessment. If they fail that, then we'll go on to asking them some questions that you and I would be able to answer. Are there fish in the sea? Does 1 pound weigh more than 2 pounds? Questions like that, and if they're having inattention or disorganized thinking, they won't be able to appropriately respond to those questions. So then we need to start looking at what could be causing the disorganized thoughts, whether it's becoming more critically ill, or whether they're sleep deprived, or whether they're not adequately medicated for pain, or there's just a lot of things that we look at that
A number
point.
of factors that could
Correct.
cause that. So once you recognize that there's that disorganized thinking, you start sort of eliminating. Now, sleep deprivation in ICU, seems like it's almost a given.
It is often, so we're trying desperately to change our workflow so that we're not interrupting the most critically ill patients so frequently. We're trying to coordinate with the respiratory therapists and the lab technicians that we only go in there together at one time and get all of our work done so they can have a few hours of uninterrupted sleep. We're trying to make it quieter in the ICU at night. Night shift, currently is trying to keep the lights down, keep the noise down, and that's always a challenge with all the bells and whistles that we have with
Sure.
all our equipment.
Yeah, I mean, I think there's a baseline of stuff you can't get rid of, but it sounds like I noticed some of the nurses, I was at a meeting the other day, and they have a button that says quiet.
Yes.
Is that part of the...
That is part of it, trying to remember, even though we're working 24 hours, that patients still need to
Patients.
have quiet time so that they can get adequate rest.
Right, right. And then suppose that it's something that has to do with, so you identify it's not sleep deprivation, and if it's pain, you have a approach to the pain.
Correct.
And but if someone's starting to get more critically ill, then of course you'd start dealing with that, which might mean more activity because maybe they need more care.
Yes.
Yeah. So wow, what a challenging thing to try to balance all those pieces.
The staff has been very engaged. I've been very happy with our progress. We've become very interprofessional, so we are working together as one team with respiratory therapy and with pharmacy. Everybody's going in together and coming up with a daily plan. So that's one thing that our patients and visitors will see now. We've implemented daily rounds in our ICU. So at 8 o'clock every morning, Monday through Friday, the whole team goes into the patient's room. We all introduce ourselves to our patient and the family, and we talk about what the plan is for the day. So it's usually the doctor, the nurse, the respiratory therapist, the physical therapist, the dietitian, and the case manager.
Giant team.
A lot of people coming all around the patient's bed and talking about what the challenges are for the day and what the patient and the family can expect, and giving them an opportunity to ask questions and participate in their care.
Now that is real intensive care.
Yes.
You know, to have a team like that focus on you.
And it really has been well received by our patients.
I'm sure. So is there anything that you would like people to remember when they come into the ICU to visit somebody? Is there some way that like visitors can help participate in this liberation?
Yes, as I said, the visitors need to continue to speak to the patient even if they appear to be sedated. Let them know they are there. Bring pictures that are familiar to the patient, loved ones, pets.
Pets?
Patients respond to pictures of their favorite dog or their
pictures of
cat.
pets, okay.
Right. So
no dogs in ICU.
No dogs in ICU, but bring pictures so that they can stay oriented to, what's important in their life and help them get through that critical part of their illness.
And if they have questions, if a family member has a question, is there like a team lead that they should
Their bedside nurse would be the first person for them to go to.
Okay.
And if they can possibly be there for rounds at 8 o'clock in the morning, we would love to have
that's
family
wonderful.
be part of the rounds so that we can all talk. A lot of times family have important information that we would appreciate from them that the patient's not able to provide.
So show up at 8 o'clock and you'd be allowed to do rounds with the doctors.
Correct. We would
That
love
would
to have
be
them
excellent.
participate.
Johanna, thank you so much for
Thank
coming
you.
to talk about
Thank
this
you so
important
much.
program. Okay, gang, it's over again. We got one more week to go, so tune in next week to Today's Seniors Living Well, and we'll have some more exciting guests to talk with.
Today's Seniors Living Well was made possible in part by the Amador County Board of Supervisors. Chairman of the Board, Dis Forrester, serving the areas of Amador City,